Welcome, everyone, to Pelvic Physical Therapy Distance Journal Club Tone Talks #2, focused on terminology. Which words should we use to describe pelvic floor muscle tone? On the call tonight, we have Megan Schwennick, myself, Beth Shelley, MJ Strawhall, and Ann Dunbar. I do want to make a disclosure right at the beginning because we are going to be talking about a document that I was involved in writing, the ICS terminology document. And that is why I have invited a myriad of other voices in order to discuss these terminology issues. This, again, is the second in the series of Tone Talks sponsored by the Pelvic Physical Therapy Distance Journal Club. And what we do recognize is that words inform thought process. And I have seen this over and over again in my mentoring, not only of beginner pelvic therapists, but also those studying for the WCS and those who have been in the field for a very long time. So it really goes across the board that using not quite exactly the correct term then brings the thought process down a rabbit hole in the wrong direction that ultimately may affect treatment and in the end affects the outcomes. So this is an important recognition. We are working to improve our understanding and thought process in pelvic PT. We're all learning. We're all hoping to be better. And we are working towards unpacking a recent systematic review that was discussed in the January Pelvic Physical Therapy Distance Journal Club, what we call Tone Talks #1. We'll see a little more of that in a moment. And we're also going to be including the ICS terminology. I thought it would be helpful to look historically at where these terms began, particularly in the United States, because that's what I know, being involved in the beginning. Way back in the 1990s, we began to teach pelvic therapy to US pelvic PTs, and there were several different people teaching, and we recognized the need for unity in terminology amongst these different groups. So about 12 therapists were brought together in one location for a weekend, and we discussed and argued and brought up research and agreed and ultimately came to what's called the gynecological manual. Now, some of you that are more recently coming into the field may not be familiar with this document, but it was what some people call the Bible initially. It was what we went by in 1997, published by the Section on Women's Health. It was a consensus, again, many leaders in the field that agreed ultimately. And we came up with 4 diagnostic categories that you see listed here. And you can see the term hypertonus dysfunction, which has in some ways, unfortunately, stuck. One thing that we really do need to correct. We've moved beyond this structure. So I want you to recognize that it was then, and we are moving forward now. So today, we have what, why, and when. What, many different words are being used incorrectly. Why, words inform thought process, and thought process informs treatment. And when, a big fat now. We need to be better at using accurate words as much as possible, especially in publication, research, and teaching. So that's part of the background of what we're doing here. Here are the 2 papers that we're going to be working through to some degree, but there certainly are others in the literature. The document that we have here, International Continence Society Report on the Terminology of Pelvic Floor Muscle Assessment, was reviewed in the Journal Club last May 22, I believe. 21. And that is available as a recording if you'd like to listen to that. This is a consensus document. It was multiple rounds. I think, over 100, really, if you look at all the different discussions, 4 years to create, and involved in the working group physicians, a nurse, physical therapist from all over the world, many languages, many professions, and we also brought in many experts. And as a consensus document, we did have some arguments and some disagreements. And when you come to a consensus, sometimes you have to agree that it's not perfect, but this is where we are right now. So this is kind of the place of this document. The other paper, more recently published, Evidence for Increased Tone or Overactivity of the Pelvic Floor Muscles in Pelvic Health, a Systematic Review. This was Tone Talks #1, reviewed in January of 2023. And they also looked at terminology, but in a very different way, collecting all of the terms and putting them into categories. So we'll see some of that as we go forward. There are several things that are in agreement between these two documents, and I think many of us can agree with these things. Tone is complex, and we're just beginning to learn about it. But I have to say, for my own self, I am very excited with what I see. This is a really exciting time in pelvic therapy, especially in regards to tone, because we are learning more and really drilling down much more specifically, good research being done. We also agree that the term hypertonus, previously in the gynecological manual, we are from this point forward only using to describe increased tone in a patient who has a neurological condition. So that is agreed. We also agree between these two documents that tone is the best term to describe the cumulative recognition of passive and active components of human skeletal muscle. We'll talk about some of the other words that are out there also. We also know that it's important to select terms that describe the muscle property being tested. For example, we only use the word activity if we're measuring with EMG, because it is the only thing that measures the active component of tone. And we only use the word elevation. This is a movement. So we're visualizing that movement with our imaging ultrasound, and we're palpating that movement with digital palpation. Accurate terminology is essential for research and is the fastest path to advancement of good research and a full understanding of the condition, which ultimately results in correct understanding of treatment and better outcomes. So I'm going to pause for just a moment and ask the other people on the call if they have any thoughts on these ideas.
So Beth, thank you for that introduction. I do feel that part of the reason we're doing this Tone Talks 2 is to really hone in on the terms that are being used. So even though we say there's agreement that tone is the best term to describe the passive and active components of the human skeletal muscle, that isn't what happens across the board. There are those who don't want to use that term because of the emphasis that may show up in regards to a neurologic condition. So in other words, there are groups that feel like tone should only be used in a population that is looking at those with a neurologic condition. But as you mentioned in our discussion before we made the recording, that we're all sitting here and we would all say that we have resting tone in our muscles, right? And so I do feel that this is part of why we're doing this talk, is that there is a lot of confusion and a lot of other thoughts about these terms. And so that's one of the reasons why we're doing this talk.
Exactly. And with reference to the last bullet there, in the past literature, and we'll see this in just a moment, There has been loads of different terms out there. And unfortunately, when you use all of those different terms, you create confusion, and it makes it very difficult to know exactly what people are talking about. So yes, it is challenging. And we have a long way to go. And again, I'm excited because I feel like it is going to become better as time goes on. So stay tuned and recognize the advancement that we're working towards. But there certainly are some that are discussing differently, and that's why we're here. And here is a piece of that between the systematic review and the ICS standard terminology. There are a couple of different suggestions in the documents. In the ICS terminology, the document talks about increased tone. Increased tone has two possibilities. It can be increased tone as a diagnosis, which has symptoms, signs, and investigations, and occurs in a patient without a neurological condition. Or you can have increased tone that is palpated as a sign. So you would want to clarify which one you're actually talking about. The systematic review suggests that the term, the better term, is greater tone. Instead of increased tone, greater tone. MJ, do you want to speak to those differences in words?
Well, I think what we understand is that when you use increased or decreased, that the problem is that we don't have normative data. There's a suggestion from the systematic review that you use greater or lesser because it is comparative to, say, other patients that you've assessed in the clinic. But then, of course, then you have to suggest that maybe the more experienced you are, the greater you are able to detect whether there's greater or lesser tone. However, that's not what the research says. So again, it's another area of confusion, because I'm not so sure increased, decreased, greater, or lesser are better than each other.
Anne or Megan, do you have another thought there?
This is Megan. I think that what MJ said is right on the money. There is confusion and it ends up being a little bit circular. The more that we talk about it, the more that we still have questions. That's how it feels.
Yes, and in some cases, the English language is limited, and we only have certain choices. But there we are. Similarly, we're going to come into the issue of elevated resting activity and higher activity. Now, remember, when you see the word activity, we are talking here about EMG. And whether it's elevated or higher, it seems to have the same issues as increased and greater. Although some people feel that higher is more accurate and some people feel elevated is more accurate. The when we come down to the end of it, we don't have normative value on any of these things. But I do want to point out the term overactive pelvic floor muscle in the ICS terminology document is referring to a finding of signs which gathers together 1, 2, or 3 other findings. And they are elevated resting activity, slow de-recruitment, and inconsistent resting baseline. So these 3 individual findings in any combination can bring you to the finding of overactive pelvic floor muscle. So it's a bit more than just higher activity. Elevated resting activity would be synonymous with higher activity if you want to use that direct connection. But overactive pelvic floor is a more cumulative term. Does that make sense?
Yeah, Beth, and I just want to clarify too that when we are using the term tone, Just to reiterate that there are passive viscoelastic properties of tone, and there are active musculoskeletal or myogenic properties of tone. And so when you're talking about elevated resting activity or overactivity, higher activity, this is only the active component of what right now we're using the word tone, not the viscoelastic properties. And so you have to have an investigation to help you determine that.
Absolutely. EMG is the only way to document the active component of tone. And as we go further with what we're calling tone talks, we're going to take a deeper dive into each of these different tools, the tool of palpation, the tool of EMG. We'll even look at ultrasound and how it measures what we can do with dynamometry, manometry. So we do want to continue discussing clinically, how do we measure? So stay tuned. Right now, we're focusing on the term, the words that have been used. So again, from the January Journal Club on the blog that you see here. So here is the Distance Journal Club blog. On the tab that says Tone Talks, there is the recording and the outline of the talk. I would encourage you to take a look at. And the third part of that document, of the systematic review document, was a thematic analysis of terminology. It occurs on page 13 and 14 of the article and includes supplement 8, the last 2 pages of the document. They collected in the literature all of the articles, many, over 100, 151, wasn't it? 151 articles in this systematic review, came up with 216 terms describing increased tone. Wow, it's like a mind blow. All of the variety and confusion that there is out there. But what was done by the authors is to create 6 clusters. And that's what you see here in this table of supplement number 8 of the systematic review. This is a list of terms found in the literature, not a list of suggested terms. It's just all of them, partly pointing out the big confusion that we have. And when you're looking at this supplement 8, it took me just a little bit of time to figure this out. So I want to, give you the cliff notes, so to speak. It is a 2-page document. So you can see here, I have printed it off, and it is 2 pages long. But what you want to do is read down. So start on the first part of that table and then go to the second page and keep reading. And then go to the middle column and read down. And then go to this column and read down. And if you were to take each of the headings from that table, this is what you would get. A lot of terms, which even are broken up even further. So what we thought we would do as we move forward here is to take a few of these. We're not going to discuss all of them because that would be far too long, and not all of them are good terms. So we're going to take a few of them, and we're going to bring up some of the issues around why we would or wouldn't use them, or what they're doing with literature. The first category of the 6 is combined passive or active tone. And one of the words there is the word tension. Now, it's interesting to recognize in physics, tension is defined as a pulling force transmitted axially, with the opposite of tension being axial compression. So this is not what we're talking about with pelvic floor. We cannot stretch axially on the pelvic floor muscle unless we remove the muscle from the body, which is done in rat studies, and they have done some of this tension recognition. So when we think truly about compression, we're not thinking about this, we're thinking about this. We're thinking about perpendicular to the muscle fibers. And that is what is recommended as the palpation test of tone to provide a force perpendicular to the muscle fibers as a compression, measuring the resistance of passive stretch for the measure of stiffness or tone. So just even recognizing that this is a confusion can be problematic. But I went even further, and I went to the internet. Not to say that everything you read on the internet is correct, but I looked for other definitions of tone, and I did try to go to places that would be more reputable, such as you see here. This first one is a glossary. This one here is a dictionary, and here is a particular course. So I tried to be a little bit more accurate, if you can use that word, but just to recognize one of the definitions. A muscle tension refers to the condition in which muscles of the body remain semi-contracted for an extended period. Muscle tension is typically caused by the physiological effects of stress and can lead to episodes of back pain. Another definition, muscular tension refers to the condition where one or more muscles remain semi-contracted for a prolonged period. This causes small lumps or muscle knots, which you can feel by touching the affected area. Any muscle can feel stiff or tense. And another definition, the force generated by the contraction of the muscle or shortening of sarcomeres is called muscle tension. Now, I have to say that for me, that last bullet is really the definition of strength. That is not the definition of muscle tension. That almost word for word is the definition of strength, the item of strength. But again, you can see such confusion in what actually is muscle tension.
I think
So
there's a
let's
difference.
open up the mic and see what you guys think of these terms, definitions.
That's in the discussion there about what you just said, the force generated by the contraction. I think the distinction might be using the word active contraction of the muscle would be more indicative of a muscle strength as far as the force, because strength should be an active measure. So that isn't in that definition. I agree with what you said, but I also think if it said active contraction, that would be more a measure of strength.
Maybe.
Perhaps they're thinking more of a passive in this, the force generated by a contraction of the muscle.
I'm not sure.
It doesn't say that.
No, I'm not sure what they're thinking, but the words force generated by a contraction of the muscle those are the words that describe strength.
And I also think that this is a good example of why the words matter.
Yeah, absolutely. Because
that's exactly the point.
How do we know what we're supposed to do with this person when we have these confusion of words and terms? And, here, in this one here, we're talking about this causes small lumps and muscle knots. Really? Do we know that? Where's the research that tells us that a semi-contracted muscle causes lumps and knots? Now, there is some evidence we'll see on this one here, the possibility that there can be some effect, a change in the muscle, if you will. This word tension here is defined in the Bow standardized terminology document. This is the conservative management document. Tension may have a similar meaning to tone and stiffness. And we do recognize that tension falls under tone. But the hard part is that we're not exactly sure whether it's the active or passive component, because we do need to capture both. So MJ, what do you think about all of this?
Melissa Davison article in front of me, and I was just looking at the definitions that they use. So this is the article, Is It Time to Rethink Using Digital Palpation for Assessment of Muscle Stiffness?
Which is going to be discussed in the February Journal Club. Please join us.
Yes. Yep. So this is our next upcoming talk. But she specifically says muscle strength is typically defined as the voluntary active contractile force of the muscle, which is kind of what Meg was saying, while muscle stiffness is typically defined as a measure of the extent to which the muscle resists deformation in response to an applied force. And so that deformation is used for lots of different terms. So tightness, tension, tone. However, when we look at your previous slide, and it said that the muscle tension is typically caused by the physiologic effect of stress and can lead to episodes of back pain. One of the things I think that we do automatically in our mind, at least I know I do, it's kind of a knee-jerk reaction, is that tension must mean it's associated with pain. And that's not always the case. Just like we know that as we apply a force and feel stiffness, you might have stiffness, increased tone, greater tone, but that doesn't necessarily mean that the patient's going to report pain. And so we have to make a distinction that just because we find increased tone, increased tension, increased stiffness, greater tension, whatever term you're going to use, doesn't necessarily mean that there's going to be accompanied pain complaint.
Yes, we very well put, and we will see that when we come up to the diagnosis of tension myalgia for sure. Here we are in the same place that we started, a lot of terms and confusion. But the word tension is maybe not quite, in my mind, is not quite as encompassing. It tends to lead us just down a small, narrow path, whereas the word tone is more encompassing of both the passive and active components. So moving on from there, we have already used this item right here, resistance to passive movement. So this is when you take your finger and you are pressing and judging the resistance. That seems to be the agreed upon description of what we're doing, and allows for less or more, greater or lesser, increased or decreased, whatever the terms are. We have a gradation. But there are other, sorry about that, there are other terms that you see here: firmness, hardness, tightness. These are words that have not been included in either of the documents, but are sometimes used in clinic. They may be confusing, partly because there isn't a counteracting. So do we say less tightness and more tightness, less hardness, or more softness? So there, again, it's very vague and very relative. MJ had said previous in our talk tonight that it is very complex tone, and the most accurate way is to include as many different measures as possible. Measures like investigations, which will give us an actual objective number, that either a distance or a force or a microvolt, that will help to be more objective in our measures. The next category in the systematic review thematic terminology is pain. So we're going to take a quick look at a couple of those terms. The term myalgia, defined in the terminology document, is a diagnosis. First of all, it is a diagnosis. It has symptoms, signs, and investigations. The symptom of pain, tender, ache, and discomfort, and the signs of muscle tenderness or tender point on palpation, with normal tone in the pelvic floor muscle, whether you're touching on the outside or on the inside. So the resistance to passive movement is normal, but the patient says it hurts. That is the diagnosis of myalgia. The questions are in the box, recognizing that this is not perfect. And as we go forward, it may change. but we wonder, is a mechanical muscle condition myalgia, or is it the result of the nervous system? Does the word inform our treatment? And where does the pain really come from? For me, if a person has normal tone and myalgia, I am immediately thinking central sensitization, or at least peripheral sensitization, that it does inform my treatment because I am concerned about the nervous system. And as recognized in the terminology document, you can't really separate out the nervous system from the muscular system. That document describes the neuromyofascial pelvic floor because we know they're together. Others have a thought?
Well, first,
Go ahead, MJ. So I work with a lot of other therapists that educate quite a bit on the pain topic. And that has been something that we've spent a lot of energy on at our facility. So the topic of pain neuroscience education would definitely wrap into the topics of myalgia. And the thought from a lot of those therapists is you may not actually have a current actual muscular issue, but the pain is coming from central sensitization theory. And so I think that could be true in some of the myalgia concerns. I think we'll go into a little bit more depth concerning further myalgia terms on the next couple slides. So I'll wait and let's see what MJ has to add.
Well, actually, I was just going to go back to some basics just so that we're clarifying, because words have meaning. So when you say symptoms and signs, it's important to understand that symptoms are the report that the patient gives us.
Right.
Signs are things that we test. So whether it's with our digital palpation, and then there's investigations, which are also signs, right? And so you pair, well, that's the old terminology.
Is the third category.
Yeah, but what I'm saying is it's different from symptoms. So,
correct.
So just to clarify that symptoms are patient report, signs are things that we test, and then you correlate them with investigations like EMG. And so I just wanted to clarify that so everybody's
absolutely
on the same page.
Very, very useful. And again, we're talking about a diagnosis here, so we really want to clarify as many things as we can. Now, the investigations with myalgia, interestingly, any investigation that measures the combined tone, passive and active tone, would be normal. EMG in this diagnosis technically would be normal. So there is normal tone. Now, the investigation could be algometry, which is the pressure. So you have a little button on your finger that measures pressure, and you press into it and ask the patient when it hurts, and they are recognizing at very low amounts of pressure that there is a pain activation. So that would be more of an investigation around myalgia. All right, next term is tension myalgia. This is defined, again, as a diagnosis with symptoms of pain and tightness, signs of muscle tenderness and increased tone on palpation, and investigations documenting increased tone, either the active or combined. It is described in Table 21 of that ICS terminology document. Now, as MJ has recognized, and we have said this before, everyone agrees that you can have a patient only with increased tone without pain on palpation. You can have a patient only with myalgia without increased tone. These are separate items. They can occur separately in a patient, but it's also possible to have both of them together. And if you do have both of them together, then using the term tension myalgia as a diagnosis, supported by symptoms, signs, and investigations, is appropriate. Now, how does that inform our treatment? Well, still, in my mentoring, I encourage my students to keep them separate in their mind, even though they are occurring in the same person. I will ask them, what are you doing in that treatment for the increased tone component of tension myalgia? And what are you doing for this patient in treatment for the myalgia component of the tension myalgia? So we want to make sure that we are recognizing there's two components that we need to keep working with and try to separate them out. I suspect as research goes further that this will become more clear which things we are doing for increased tone and which might be more myalgia based. I suspect there's going to be a whole lot of overlap and some muddy water in there too. But trying to keep in your mind the recognition that, as we see on the third bullet here, combining these terms should not imply that pain is synonymous with tone and vice versa. They are not mutually always together. Separate things to be measured, separate things to be treated. So, should we always keep them separate and never use the combined tension myalgia? Or should we put in a clarifier that tells what we understand about the tone component in order to inform treatment better? Remember, the things in the black box are the questions that are being discussed further. We don't have all the answers here, but it is helpful to recognize things that need to be discussed. Thoughts from the group?
Some of my thoughts about the tension myalgia topic are leading me to think about patients that I've seen and how they progress through their physical therapy treatments. Do we typically see changing? If you have a patient that has pain and has what we would classify as increased tone or increased, whatever we decide, greater tone, and you have both of those scenarios, sometimes you'll see one thing improve. The patient may still complain of pain, but the therapist believes now that the tone or the palpatory decision, greater tone, increased tone, is now closer to what they would consider to be normal. So would that change how you document and how you use your coding and things like that? Would that be a benefit to having a separated coding? That would be one way to think about why you might want to separate them, because continuing to call it tension myalgia when in fact it might be just a myalgia or just a tension of some kind, that might be more appropriate. I'm not saying we should do that, but it's just a thought.
And I'm not sure about you guys in your field. I don't have a big coding department that I work with, but it's not unusual for me to change the diagnosis. Now we'll just tap on coding a little bit later, but certainly we might recognize partway through when we are reevaluating. This is sort of what I call the onion. You know, you have this outer thing that you can tell what's going on in the beginning. And as you start resolving things, you're peeling back the condition, and you might actually change your direction. You might actually officially change your diagnosis. And that is exactly what you described. Absolutely.
I think unfortunately, that may bring up some concerns with insurances in some cases, because I think you have to put in the primary diagnosis, and if that changes, it could affect some of the patient reimbursement. I'm not 100% sure on that, but I'm sure that there's issues there somewhere. If there's a way the insurance companies can make it a problem, probably.
That is a whole nother animal. And so really what we're talking about, it primarily is the thought process that you use in order to inform your treatment. What you write in the chart may be a different thing. But as you mentioned, Megan, your thought process might recognize after a reevaluation that now we are more clearly aligned in a slightly different diagnosis than what we started with. Yep. MJ?
Well, this is opening up another can of worms, but that's what this talk is all about, right?
Yes.
So it just dawns on me as we think about tension and tone and associated with pain or not associated with pain. Typically, we would be testing for muscle strength as well. So most of us use the modified Oxford scale, right? And so if I am testing for muscle strength and a patient's already starting at a higher resting tension level, tone level, okay, greater tone, I am going to register that strength as weaker because they're starting at a higher level, so there's not as much movement. Does that make sense?
True, but I'm not sure that is supported by the research. There's some new stuff coming out that's looking at that. And personally, MJ, I don't do a manual muscle test. I don't do a digital muscle test on a person who has increased tone because it doesn't help me.
Yeah, that's my point. Should we be doing that? And I would suggest that no, we shouldn't. However, you know, if I treat a lot of Paris women and they have great laxity in their pelvic floor muscles, and then I treat somebody that has maybe more normal tone, and again, we don't have a good standard, I might consider that person has greater tone because all my other patients have had lesser tone. So I have a problem with the fact that it's a comparison. Where's the increase or decrease, greater or lesser? There's got to be a comparison. So if all my patients previously actually had more laxity, for want of another term, then, you know, when my next patient comes along and has more tone than they do, am I going to call that tension or greater stiffness?
And this really does speak to how we train therapists.
Yeah.
And how do we do the very best that we can in the clinic to have a structure of what we think is normal. And again, Megan is going to lead us in February with a suggestion on how we can do our very best. But it's not easy. And personally, I feel like as you are working with a mentor in the clinic and you touch the muscle and you say, this is what I think, and another therapist touches the muscle and says, this is what I think, somehow talking it out and working together to come up with what we think is normal, that's probably our best way. It speaks to the residency training and how that can be more objective in some ways. But MJ, you bring up a really interesting discussion, which I think we should look at again in another Tone Talks. What we have said here is increased tone should not be confused or melded with pain in a muscle or myalgia. Similarly, decreased tone, we need to be very careful not to synonymously meld that with weakness or strength. So these are things that can sometimes get, kind of gray together, and they really shouldn't be. We need to be as objective as possible in measuring each component of the muscle property and using investigations as much as we can. So moving on, these are the devices, the tools that were used in the systematic review to measure tone. We are going to pick them apart. There is a future publication by that same group that should be coming out soon, and we will have another talk. But this next paper took each and every one of these tools and looked at the psychometrics, what we understand about reproducibility and validity and those sorts of things. So we're going to weed down further on these tools. But I thought it would be interesting because this document did bring up the shear wave elastography, this item here, to just introduce this to people as we are learning more about tone. Shear wave elastography measures shear modulus, which is an estimate of stiffness and is a combined, so it is passive and active tone, and it is measuring indirectly the tone. So that's how it sits in our understanding, combined passive and active and indirect, but it is very objective. And that's what you see here. The bottom is the image that you would see from your B mode ultrasound, what most therapists are using. And when you flip the switch on the shear wave, inside this box, you see the variety of estimate of stiffness. And you can see that here, where up at the top, we have more stiffness or more tone, and you can see variety of areas, and then a little bit less, and a little bit less, and a little bit less. So you could take this image and quantify the area of each one of these, red or yellow or blue, depending on what you're looking at, and be much more precise. Does this not excite you guys? Because I'm just like, wow, this is so awesome, because now we don't have to guess. We don't have to worry that it's our finger that's measuring something more or less, and we can really be more objective.
So Beth, it's exciting. However, this tool isn't going to make its way into the clinic and isn't going to affect my practice anytime soon.
It is going to affect your practice. I disagree with that, because what it's going to do is it's going to be able to measure, this is the tone before an intervention. Do the intervention, this is the tone after. It is going to ultimately it's not a tool we're going to use, but it is ultimately going to result in much better ability to understand what we're doing and inform why we're doing, and throw out things that aren't helping, that we thought were useful, but it doesn't come out that way. That's my excitement.
Yeah, and I think, again, I'm going to be excited to see what the research shows. But, you know, the utility in the clinic, that's not going to come for 10, 15 years, you know.
It's not meant for that. No,
yeah,
absolutely. We agree. The next term in this pain place is trigger points. The definition in the ICS terminology, the most frequently cited combination of diagnostic criteria are paired criteria of tender point in a taut band and predicted or recognized pain referral form. This is discussed in table 22 of the myofascial diagnosis. Unfortunately, there are no consensus regarding objective laboratory tests for myofascial trigger point diagnosis. Some consider trigger point to be a combination of active and passive tone, and some feel it's a category on its own. Unfortunately, the reproducibility studies have not demonstrated good ability of two raters to find the same trigger point or taut band, and it is suggested by many that tender point is more accurate, because we really can reproducibly recognize tender points. That has been shown in research, that we can find a point that the patient says is tender. Now, this is a clinical sign. It is a piece of the assessment put together with symptoms, other signs, and investigations to ultimately arrive at a diagnosis. A few words there, or shall we move on? All right, let's move on to the active component of tone. Words descriptive of muscle activity should only be used as a result of EMG assessment. This is the only way to describe the active component of tone and is a very valuable tool in the clinic to help patients change the active component of tone, whether we're trying to increase the activity of that particular muscle or decrease the activity. And we've already said the term overactive and similarly the term underactive is only used when measuring with an EMG. In the box, we have some questions and thoughts. The question of whether the best word is over with overactive or whether it should be higher activity. And we kind of addressed this at the beginning, so I'm not really sure that we need to go into it again, but recognizing that this is a relative term, that we don't have normative data, and especially when you put it together with what you see here on the slide is inconsistent resting baseline. And I don't think that anybody can disagree that this is not desirable, that this kind of inconsistency is demonstrating some condition, some situation that it would be helpful to change. More data, more research to come for sure. And then also recognizing the slow de-recruitment as another component in this way. So there was another term we found in the internet, the term over-recruitment. Now, recruitment can take several different definitions. In the ICS terminology definition, recruitment refers to the initial tightening, the initial activity of the muscle. So what you would see right here. So this would be recruitment, that portion there. And then de-recruitment is this portion, the back end of the person's ability to relax. So what does over-recruitment mean? Any thoughts from the group?
Well, if I was thinking over recruitment, it doesn't imply what the baseline is. And so over recruitment could just be better muscle activation. And as long as the de-recruitment looked fairly good, to me, I wouldn't call it over recruitment. So I think that term comes with a whole bunch of other problems, and it is only that active component, right? Not
Absolutely.
the passive component.
Absolutely.
Tone, right? So you could only use that term if you were talking about the active component.
EMG.
Right, exactly. But I don't think you can use the term over recruitment without looking at de-recruitment.
I'm with you.
Right.
We need to look at all the different components in order to understand what's going on. Singling one little smidgen out, it doesn't really help inform treatment. Neurogenic terms were also discussed. The term spasm is a persistent contraction of a muscle that cannot be reduced voluntarily, with some clarification there. In the ICS terminology document, spasm is used only in patients who don't have a neurological condition, but that was placed as a question. In the ICS document, the term spasticity may be the sister term, if you will, in a patient with a neurological disorder. So that is muscle spasm. And then dystonia. Dystonia is defined also in the ICS document as a disorder characterized by abnormalities of muscle tone and movements or postures in a patient with a neurological disorder. So only used in a patient with a neurological condition. And that seems to be a fair agreement, but how do we test dystonia? And how do we really know if it's a spasm? Again, we really do have a long way to go. And recognizing that maybe these terms are not perfect, we're looking towards more clarity of research. Comments or thoughts? All right, our last individual discussion is from the category of function and dysfunction, the term non-relaxing. Now, in the Mesolink document, the original pelvic muscle assessment document from 2005, non-relaxing pelvic floor muscle was a diagnosis. That is really too narrow. It is not a diagnosis. It is, in the current ICS terms, one finding of signs. The test, relaxation after an active contraction. And I've put here the ratings. So when you ask a patient to do a squeeze and then to do a relax, you are grading the relax as full, partial, delayed, or non-relaxing. It is a finding of one test in signs. But you cannot rate that if the patient is not able to contract. And this speaks to what MJ and I were speaking about earlier. If you have a patient with increased tone, you would probably not grade their strength. And because you're not grading strength, then you can't grade their ability to relax after an active contraction. But if they do have some ability to contract, if they have adequate contraction, then you can judge their ability to relax. Be as objective as possible. There are no norms. This is really quite subjective, and there are instruments that are going to be more accurate in grading this finding. Megan.
I have a clarification question. I think it's a question. Would you consider those options, full, partial, delayed, and non-relaxing, to all be mutually exclusive? Or would you combine the phrase delayed with a full or a partial?
Well, a delayed implies full. So in order to qualify for delayed, the person has to get all the way down.
I was thinking about it from maybe a partial, but also not really starting to relax from a contraction quickly. So you tell the patient to release the muscle, and then it's delayed, but also does not fully relax to what you believe is a full relaxation.
Yep. And so if I found that it was fully relaxed, I would call it delayed. If it wasn't fully relaxed, I would use both partial and delayed. And I do use that combination.
Okay.
So
Okay.
it would not be wrong to use full and delayed as a very clear explanation. It would not be wrong to do that. Other thoughts? So as I mentioned, we're just gonna really tap on coding. This could be a whole another discussion, which we're not going to get into tonight. In the ICS document, it is recognized that not all the terms in the document have corresponding ICD-10 codes. And the WHO themselves recognizes that codes that describe symptoms and signs as opposed to a diagnosis are acceptable for reporting purposes when a relatively definitive diagnosis has not been established or yet confirmed by the provider. So it really is helpful to keep those boxes separate. The numbers that we use for coding are unfortunately misuse of the original reason. In 1948, the WHO created ICD codes to identify health trends and facilitate the international reporting of diseases and health conditions. ICD-10 was never originally designated as a classification system to code patient encounters, determining insurance reimbursement, and determining other decisions impacting access to patient care. This is not how it was originally created, and we really do need to recognize the limitations of our coding system. Now, in the United States, that's what we have. So it is what it is, and we can't change that. But for me, when I am mentoring therapists and in my own practice, I really do keep these two things very separate. I have things that I'm using that are essential for reimbursement and access, and that's important, and we need to be as accurate as we can be. But on the other hand, in my own mind, in my notes, I am classifying that patient with the terms that I feel are most accurate and informing my treatment based on those things, not necessarily the numbers, although they really do need to match. That is true. MJ, do you want to say a few words on that?
I think that we all have the dilemma when we get referrals from outside sources rather than direct access, that patients come to us with varying kinds of medical diagnoses that don't always pair well with our physical therapy CPT codes. And so we all have the ability to create a physical therapy diagnosis, and we should do that to the best of our ability using exactly what we're talking about, the symptoms of the patient and any signs that we can test for, in addition to whatever investigational tools that we have in the clinic, to make the most accurate physical therapy diagnosis that will pair better with our musculoskeletal, typically CPT codes. And that's always been, I think, a dilemma for everybody, because we'll get these very generic diagnoses, or quite often I get the diagnosis of vaginismus, which I really dislike because that is a sexual dysfunction and it doesn't pair very well with our CPT codes. And the actual description of vaginismus in the DSM-5 doesn't even require palpation to give you that diagnosis. And I think that was recognized, so that when they were creating the new DSM, they came up with the genital pain. What was the rest of it, Beth?
Penetration disorder.
Penetration disorder. But in my case, I would want to be more specific to, what actually the patient reports, in addition to what I actually find with either palpation or investigations. And so I just think that's always a dilemma, to try to create a more accurate picture, because often our referrers, they don't know what to call it. They just might just say pelvic pain.
Yep. And I think the word dilemma really does describe it well. It's difficult and it creates problems, and unfortunately sometimes limits access. But again, I personally think that it is possible to have a thought process in line with the literature and the terminology and clarity that might be a little bit different from the actual coding that we're required to use. So in conclusion, this is an exciting time in pelvic physical therapy. We are going to end where we begin. Words inform thought process, and thought process informs treatment. We have a lot to learn and a long path ahead. And we are challenging all clinicians to continue to grow and keep up with the research. And that's what we're hoping in the Pelvic Physical Therapy Distance Journal Club to facilitate. We hope that all professionals will try to adhere to an international consensus document as much as you can to increase clarity of communication among professionals. Document clearly when you diverge from the standard terminology and why you are using different terminology. And this is absolutely essential for researchers, people who are publishing and teaching, understanding that the terms may change over time as new evidence emerges. Tone Talks, as I mentioned, is on the blog, and this again is the link there. What you see, this screenshot is the recording of the journal club, as well as the outline and additional resources. And we will continue to add new references in full PDF if we can, or a link to the article, or at least the reference title if it's not available open access. And we'll continue to list this talk as well as the future discussions as we continue to become even more specific. February 8th is our next monthly Pelvic Physical Therapy Distance Journal Club, and this will be, as mentioned, on the digital palpation of tone. We have 2 articles that we're going to talk about and give, hopefully, a bit more clarity so that in your clinic, you can be as objective as possible with the not very objective palpation tool. Any final discussion from our panel?
To be continued.
Yeah. Thanks, Beth. I feel like this discussion needs to continue to go on because there's so much variety and so much different thinking behind these topics that it's good that we bring it out and discuss the fact that we all have differences in the way that we see this. But at some point in time, we have to come, I think you used the word concession. So there's consensus where a large group of people get together and try to bring everybody to the middle. But that does require concessions, meaning you have to give up something.
Right.
You can't have, everybody can't have it their own way because there's too much divergence. But if we're ever going to advance research, especially in the field of pelvic health, we have to be able to come to not only consensus, but be willing to, have some concession in order to move forward, in the hope that it will be a purer science, if you will, down the road.
Mm-hmm.
So
absolutely. Well put. Anne, do you want to add a few words?
I concur heartily with what MJ just said, and believe that the consensus document the work that the professionals of different walks of life and all over the world have put together, the consensus document that really helps to inform us about terminology that's used currently, and leaves a lot of room for growth for all of us.
Mm-hmm. Great. All right, ladies, thank you so much for joining me. As we are recognizing there will be more, stay tuned and please keep in touch. Good night.
Night.